Surgery for neuroendocrine tumors. When can we cure? When should we debulk? The presentation will deliver an evidence-based review of surgical strategies, focusing on the distinct approaches required for small bowel and pancreatic NETs, the critical importance of a meticulous lymph node dissection for improved long-term outcomes, and the essential questions all patients and families should ask their surgical team. The initial diagnosis, particularly when involving metastatic disease, is profoundly challenging and overwhelming. The discussion will provide clarity on the defined role of surgery, offering a real hope of cure for localized disease or delivering significant clinical benefit and symptom palliation even when a cure is unattainable, by outlining the strict criteria for surgical candidacy. Neuroendocrine tumors arise from hormone-producing cells, with the pancreas and small intestine representing the most frequent intra-abdominal sites. It is paramount to understand that radical surgery offers the only curative pathway for this disease, with treatment spectrum ranging from minimally invasive to highly extensive complex resections. Reiterating that surgery is the sole curative modality, the procedure can be extensive and may necessitate complex vascular reconstruction, making the decision-making process critical. The surgeon's planning is ultimately driven by two fundamental, interconnected questions: identifying the necessary operation and confirming that surgery represents the optimal strategy for the patient's specific disease stage. Complete cure for localized disease hinges exclusively on radical surgical resection. For small intestinal NETs, this mandates removing the affected bowel segment alongside a comprehensive regional lymphadenectomy, while curative intent for pancreatic NETs depends on the complete excision of the tumor and its lymphatic drainage. Early detection prior to any spread remains the most crucial determinant of a curative outcome. Resectability assessment for small bowel NETs includes evaluating mesenteric masses, which are often enlarged lymph nodes, for the risk of causing bowel obstruction. Published research strongly demonstrates that the removal of these high-risk lymph nodes significantly enhances patient survival, with the overall surgical approach determined by the tumor's exact location and disease extent. Conservative options like enucleation, which scoops out the tumor while preserving pancreatic tissue, are limited to very small tumors and are compromised by inadequate margins and the inability to clear lymph nodes. Consequently, a standardized, radical pancreatic resection, which ensures comprehensive oncologic clearance, is frequently the necessary and preferred approach. The status of regional lymph nodes stands as one of the most significant prognostic factors in NET disease, and the extent of their removal directly impacts long-term outcomes. This holds true for both confined and locally advanced pancreatic NETs, confirming that a thorough, standardized assessment of the lymphatic basin is essential for accurate staging and subsequent treatment planning. Specialized techniques are employed, such as vessel-sparing lymphadenectomy for small bowel NETs, which improves outcomes despite being technically demanding. The number of lymph nodes pathologically examined directly correlates with the precision of disease staging, underscoring that insufficient sampling risks missing critical metastatic disease information and compromising the treatment plan. The perception of overly aggressive surgery is a misunderstanding, as extensive dissection and longer operating times are a direct result of evidence-based practice and survival data that necessitate thorough lymph node assessment and clearance. The surgeon is rigorously adhering to best practice guidelines to ensure the highest likelihood of a successful long-term oncological outcome. When the cancer has spread and presents with distant unresectable metastases, the surgical goal transitions from cure to palliation or debulking. The primary aim of this non-curative intervention is to prevent life-threatening complications such as severe gastrointestinal bleeding or bowel obstruction, thereby managing symptoms and improving quality of life. The practice of removing the primary tumor when synchronous liver metastases are unresectable remains highly controversial in small intestinal NETs. While some retrospective data suggested a survival benefit, more robust propensity score matched studies have demonstrated no clear benefit, resulting in mixed data that prevents a clear-cut clinical recommendation. For pancreatic NETs with unresectable liver metastases, the supporting evidence for primary tumor resection is even weaker than for small bowel NETs. A systematic review concluded that limited evidence exists, and the major surgical intervention is generally reserved only for cases where the primary tumor is causing severe, unmanageable symptoms. The management is radically different when liver metastases are deemed resectable or potentially resectable. This applies to well-differentiated G1 and G2 tumors without disease spread outside the abdomen, where radical resection of the liver metastases is strongly recommended due to its association with significantly better survival outcomes compared to non-surgical treatment alone. For extensive or complex patterns of liver spread, a staged, two-step approach may be required. Step 1 involves resecting the metastases in one section of the liver and ligating the portal vein on the other side to stimulate growth of the remaining liver volume, allowing a second, definitive hepatectomy to be performed safely weeks later. The standard operation consists of a segment of small bowel resection combined with an extensive mesenteric lymphadenectomy. The degree of bowel removal for terminal ileum or cecal tumors is debated, with surgeons weighing the trade-off between the improved staging accuracy of a right hemicolectomy and the increased morbidity of a larger operation. The tumor's location dictates the required surgical procedure. Head tumors necessitate a complex pancreaticoduodenectomy, or Whipple procedure, while body and tail tumors require a distal pancreatectomy. It is vital to note that both of these major operations carry considerable, inherent risks of postoperative complications. Patients undergoing pancreatic surgery must be informed of the overall 30 to 50% complication rate. The most common, and potentially serious, complication is the development of a pancreatic fistula, which can lead to significant postoperative morbidity and extended recovery. Due to the disease's complexity, the essential first step for all NET patients is to ensure their case is discussed by a multidisciplinary team, including surgical oncology, medical oncology, endocrinology, radiology, and pathology. European consensus guidelines insist that treatment decisions originate from expert centers, making a referral mandatory if the patient is not currently being managed by a specialist team. The preoperative workup must include functional imaging, typically gallium-68 dotatate PET-CT, which identifies tumor cells throughout the body, alongside anatomical cross-sectional imaging, such as CT or MRI, which provides the precise detail necessary for meticulous surgical planning. It is a non-negotiable requirement that the pathology report includes the Ki-67 proliferation index, which defines the tumor grade as G1, G2, or G3 based on the percentage of dividing cells. Any pathology report that omits this crucial grading information requires an immediate specialist pathology re-review. Patients should focus their questions on the core issue of resectability. Is the primary tumor removable? Can all regional lymph nodes be cleared? And what is the exact percentage of liver involved if metastases are present? The ultimate defining question is whether the surgeon can achieve a complete, margin-negative R0 resection. For localized disease, patients should ask about the realistic, achievable cure rates, while for metastatic disease, the surgical aim must be explicitly clarified. Is the goal cure, long-term disease control, or simply symptom management? A shared, realistic understanding of these goals is critical for treatment satisfaction. Patients need to be aware of the procedure-specific risks, including the 30 to 50% complication rate for pancreatic surgery and the high incidence of pancreatic fistula. Small bowel resection carries a risk of anastomotic leak and the potential for short bowel syndrome if extensive intestinal removal is necessary. Inquire about the potential benefit of neoadjuvant or preoperative therapy for borderline resectable tumors. Treatments like peptide receptor radionuclide therapy deliver targeted radiation to potentially shrink the tumor sufficiently, converting an otherwise unresectable case into one that allows for a safe, complete surgical clearance. The most critical indication for a second opinion is being told the tumor is unresectable, as the definition of resectability varies significantly between centers. High-volume NET specialists often possess the expertise, particularly in complex vascular reconstruction, to safely resect disease considered technically impossible elsewhere. Any surgical plan offered without a prior formal multidisciplinary team discussion is medically inappropriate, as a solo decision is unacceptable for NET management. Additionally, the management of synchronous liver metastases requires sophisticated, highly specialized judgment from an expert team to determine the optimal timing and extent of resection. In summary, surgery is the only path to cure for neuroendocrine tumors, with success highly dependent on stringent patient selection, tumor grade, and the extent of the disease. The expertise of the surgical center is of critical importance, underscoring the mandatory action step. Always request a multidisciplinary evaluation at a specialist NET center. For further detailed and authoritative information, the audience is directed to the official guidelines from the European Neuroendocrine Tumor Society and the North American Neuroendocrine Tumor Society, with links to these current resources provided in the description.